Good evening, everyone. Welcome to our Life in Motion monthly webinar series. I'm Caitlin, and tonight we have with us Dr. Lee-Sigler. Dr. Lee-Sigler graduated cum laude from Lewis University in Romeoville, Illinois, where she was in the Air Force ROTC and was commissioned as an Air Force officer shortly after graduation. She received her medical degree from Temple University School of Medicine. She served 6 years reserve duty and 4 years active duty in the United States Air Force. This is where she was an emergency room practitioner. Dr. Lee-Sigler went on to complete a residency program in physical medicine and rehabilitation and was chief resident her last year. After transitioning and moving to Champaign, Illinois, she served as a clinical instructor at the University of Illinois College of Medicine. She served attending staff at the Carle Foundation Hospital and served as medical director of the Inpatient Rehabilitation Unit, Therapy Services, and the Carle Spine Institute, while serving as division head for the Physical Medicine and Rehabilitation. After arriving in the Memphis area, she became an owner of Memphis Spine Center and later joined OrthoSouth. She has a special interest in treating disorders of the spine as well as other musculoskeletal disorders and offers ultrasound-guided as well as fluoroscopically guided procedures of multiple types, orthobiologics, and electrodiagnostic exams and interpretations. With her expertise and passion on this particular subject, this evening Dr. Lee-Sigler will be explaining the role of physiatrists in comprehensive spine care. What exactly is a physiatrist, what role do they play, and everything in between. Throughout the webinar, feel free to submit your questions in the comments. I'll review them and relay them to Dr. Sigler as we go along. While some questions may require a few more details about your specific medical history to be fully answered, don't hesitate to ask. If more information is needed, we'll guide you on what to do next. All right, sorry guys, we were muted. So I started off with saying thank you for being here, and let's just get started with the basics. What exactly is a physiatrist?
A physiatrist is a physician who specializes in physical medicine and rehabilitation. Physical medicine and rehabilitation is a field that focuses on improving patients' function and pain by a variety of techniques. So a person will go through medical school and then for a residency will choose that field.
Perfect. So is a physiatrist a new field or has it been around for a while?
No, it actually started in the 1920s. There was a Dr. Frank Cruzen who originally planned to be a surgeon, but then he suffered a severe illness of his own. And after basically rehabbing himself from that, he decided to study and work more in terms of developing methods to treat people who were recovering from injuries and other illnesses that were taking a prolonged time to recover. And he actually started the field at my alma mater, Temple University, and then moved over to the Mayo Clinic where he further developed it. It was formalized as a specialty in the 1940s after soldiers were coming home from World War II with all of these catastrophic illnesses that they survived, but then had to reintegrate into life with loss of limbs, loss of other body parts, back pain, other injuries to try to get them functional and to get their pain under control.
Awesome. Well, I have kind of a question for you. What made you, we heard of your background and everything, what made you go into physiatry?
Well, I originally wanted to be in another field, and when I was a third year, I think it was a third year, either the beginning of my fourth year of medical school, I was actually in a neurology rotation. I kept asking these questions about what are we going to do about this, or how are we going to get this person better, and the chairman said to me one day, I really love you. I really think, however, that you might be better suited to this field. And so these people are going to be rounding, because we rounded on the same floor of the hospital multiple days a week. And how about if you spend the afternoon with them, and if you like them better than you like us, then maybe I can talk to their chairman, and we can make a deal. And I did that, and I loved it. And so I went back to the chairman the next day, and I said, I really want to be over there. And so he helped facilitate me switching all of my, because by that point we had already chosen all of our rotations for our senior year, and he helped me switch all of those over so that I could get the rotations that I needed so that I could apply for a residency in physical medicine and rehabilitation.
Awesome, awesome. So what are some common conditions that physiatrists treat?
Physiatrists treat a variety of conditions, and I actually started on a brain and spinal cord injury unit, and so we'll treat conditions of the brain, so that's from stroke to traumatic brain injury to degenerative neuromuscular disorders, rehabbing people after back injuries, and specifically for what we're talking about today, outpatient spine is very important. We also can treat people post-amputation, and other disorders of the muscles and other joints as well. And so people will be divided, sometimes completely and sometimes not completely, between inpatient work, because there's also cardiac rehab and pulmonary rehab, and then outpatient work. So I transitioned from inpatient to outpatient work, and that training in brain and neuromuscular and spinal cord really helped me when I started working more with orthopedics and neurosurgery together in spine.
Awesome. So what differentiates a physiatrist from other physicians who treat conditions of the spine?
Physiatrists are going to do a history and a physical exam that focuses on how whatever it is the person has affects their function and their daily living. So our job is to try to find out what's wrong, and also to find out how that affects the person in their daily living, and try to find out how we can improve that person's daily living so that they can be as normal as possible in terms of their daily life, their work, all of those things. And so that's where the history is going to be different. The physical exam may seem like the same physical exam you may get elsewhere, but the eye that we're looking, or lens we're looking at it through, is so that we can try to do things to make your life better.
Awesome, awesome. So when do you step in? When does a surgeon step in? Kind of how do y'all play together, especially here at OrthoSouth with the Spine Institute?
So the great thing about the Spine Institute is that we are combining non-surgical care with surgical care, and we work together hand in hand. And so whenever you have a situation where the people who are evaluating from a non-surgical standpoint can talk daily with the people who would be dealing with a person from both an orthopedic spine standpoint and a neurosurgical spine standpoint, you're going to get a lot of additional insight into what can happen for the person, what you should be doing. So patients may come in through the physiatry. Well, so the patient may be in my clinic, for instance, and I will evaluate the person, and the goal always is to try to avoid surgery if one can. The vast majority of patients who have neck and or back problems do not end up having surgery. We need to be expert at finding out who's who and where they are on the spectrum, and even people who end up having spine surgery don't, for the most part, start out with spine surgery being the first thing that happens for them. So we try to integrate what we do. I do all kinds of medications, direct physical therapy, because generally physical therapy isn't physical therapy isn't physical therapy. So just because a person had physical therapy once and it didn't work or it hurt doesn't mean that physical therapy won't work. It may mean that you didn't have the right diagnosis. It may mean that you didn't have the right therapy. It may mean that you need to have an epidural injection or a facet joint injection or an SI joint injection or something like that before you even go back to physical therapy, so that you can get the area and the tissue in a position where the therapy can be more successful. Also, we have case conferences where we sit down and we talk about various people that we have treated, And what should our next step be? What can we do better? So we'll put their x-rays up, their MRIs up, if they have CAT scans, if they have other studies. Physiatrists often also do electrodiagnostic studies or interpret those electrodiagnostic studies, so we can read x-rays, order the appropriate x-rays. So there's some x-rays situations where you need bending films as well as just regular films. MRIs, CT scans, nuclear medicine studies. Sometimes people need to have special scans that are nuclear medicine scans, and we do and interpret electrodiagnostic studies, which people will call nerve conduction studies or EMGs. That's to help us determine whether or not the nerve has been in enough trouble where it is showing signs of dysfunction, or is there another disease or disorder on top of that, like a neuropathy. So we'll put all of that information up, along with the patient's complaint, along with their exam, and kind of go through what the various opinions are, what happened in physical therapy as well, what the various opinions are, and what would be the best next step and why. And the great thing about that particularly is that for the most part we come to consensus, but it's a really deep dive, thought through process. So the advantage is we work together, we talk together, we do case conference together, and we do a literature review together. So once a month we sit down, we look at articles together, we discuss that. And that all translates into something that should be better in terms of a more holistic approach to spine care. In addition, we have a spine navigator, which is you.
Yes.
And because sometimes people need a lot of different things, right? So they may have a bone density test upcoming. So we need to know what that is prior to surgery. They may need a heart clearance. They may have some information from another state that we're having trouble getting. Or they may need some additional help understanding what the process is and what is going to happen at each step. And so having that kind of holistic approach with a spine navigator when needed can be really helpful in terms of, and comforting to the patient too, in terms of guiding them through that process.
Awesome. So getting into physiatry, and what procedures do you perform? I know you talked a little bit about some tests, some imaging and nerve conduction study. What other procedures do you perform as a physiatrist?
So in addition to the electrodiagnostic studies, we do ultrasound guided procedures, and we can put some of those up now. I'm going to start out, I think, with the C-arm procedure. And so those are all of the what people call blocks, and I want to distinguish that, because when a person says they have a block, I still don't really know what they had done. So that could be an epidural steroid injection, and there's different approaches for that. So there's an intralaminar approach where one's just going more towards the middle and kind of slightly to the side. And there's a C-arm machine that you can show. And it will rotate around and tilt up and down and guide me to where I need to be. And then when I get there, I inject dye. Or I could come in through these holes or foramen. Now, here it would look like if a person's lying down, I would have to come way out on the side. But that imaging machine, the C-arm, will take it and tilt the spine so that I don't have to come in way on the side. I can come just slightly more towards the side at a different angle and get the target nerve that way. There's injections where we come in through what's called the sacral hiatus. We also do SI joint and tailbone injections, or coccyx blocks. We do the same type of injections in the neck, medial branch blocks. So again, a block isn't a block isn't a block. You need to know what it is that you're targeting, what the goal is, and why that's the goal. And sometimes people will have multiple targets depending on what their problem is. They could have a problem up here in their neck, but they could also have a problem out here giving them pain into their head. We need to be able to address that. Sometimes we address it using an ultrasound machine, and that is, again, where...
So I have a picture of it. So the C-arm is here, and then here is the ultrasound machine. Yeah, so for the ultrasound machine, it's a little handheld machine that has a transducer, and basically it will scan through the tissues in a different way. It images differently than the C-arm. The C-arm is going to give you kind of like an X-ray looking, an X-ray view just from multiple angles, and this will look very differently. It looks at the soft tissue better, so when we're thinking about soft tissue
problems, it will image that better, but it's also very good at joints. So I can do the same sacroiliac joint injections. You can do some facet injections, and you can do tailbone or coccyx injections and various injections that way. We also do, again, other joint injections, spinal column stimulators. So that is a device that can be put in temporarily and permanently where leads are fed up the spine to help control pain that way. There are peripheral nerve stimulators that we do as well as guiding the therapy.
Awesome. I don't want to go into too much detail about the different, I know you were pointing to different areas. Mm-hmm. What is your goal of giving an injection in the spine? Like what are you targeting?
For instance, if we're targeting a specific nerve, what you want to do, so let's say a person has a disc and it's slipped out of place and it's aggravating a particular nerve. The point is to put medication there to calm down the nerve, to decrease inflammation, and in that way allow the person to hopefully heal on their own. Sometimes we're targeting a joint, and so sometimes people will have a joint that's either dysfunctional, or it could have a small cyst in it, or it could just be inflamed, very arthritic. So just like a person can have their knee injected, you can have a joint in your spine injected. Sometimes it is the nerve supply to the joint that's a problem. So that's where we may block. There's some smaller nerves that will come off these large nerves, and they supply, multiple of them will supply a joint. Those can be blocked, and if temporarily that helps, then we can do a procedure that's called a radiofrequency ablation procedure. And that's where we put a small burn lesion in the nerve so that just the sensory part of the nerve that provides pain dies back, and the person is able then not to get the pain that comes from that joint. So it really depends on what the problem is, which is where that history and exam and putting all of that information together from that in the imaging studies becomes so very important, so that you know what is your target here and what are you trying to do.
Awesome. So I know you talked about the radiofrequency ablation. I have that picture up that you provided us on the screen, which we can come back to if we want. The next question, kind of changing gears a little bit, we went over what exactly is a physiatrist, what you treat, how you work together with other spine specialists, and then what types of procedures you perform. But how can a patient prepare for their spine appointment?
There's several things that can be done. First of all, have a clear history in your own mind regarding what happened, when did it start. Be organized for your appointment. Make sure that any information that you have from an outside physician, such as x-rays, are available. If there's already an MRI, even if it's not super recent, having that can be really helpful. Many times there's a reliance on the doctor's office that's referring to send everything over, but images can't often be sent electronically. Sometimes they can, but sometimes they can't. So it's important to make sure that all of that information is there for the appointment. Knowing when your problem started, knowing what makes it better, what makes it worse, being able to put a number to your pain. The reason that's important, a couple of things. Number one, you want to be able to compare yourself against yourself. Mm-hmm. So people will say, I have a high pain tolerance, or I have a low pain tolerance. Doesn't matter. I'm comparing you against you for your next visit. And so your pain tolerance isn't going to change, but your pain may change. Mm-hmm. And so we want to know within that. Also, we want to know, does it radiate? You know, what's the quality of it? Is it aching, burning, sharp, dull, tingling, numbness? All of those things turn out to be important in terms of what we start to think about related to your problem. I think I said this before, but what makes it better? What makes it worse? Is it there constantly or not? And being able to express that for either an intake sheet that's given, or when either the patient representative or person intaking or the physician comes in, being able to say, this is where my pain is, this is the level it is. Those sorts of things are really important, as well as having the information that's needed. If you've had medicines, and this is really a big one, know what all your medicines are. Even if you think it doesn't relate to anything I'm doing, it can relate. So there's medication interactions that we have to consider, even for your multivitamins, supplements, CBD oil. All of those things turn out to be important because it may change what we prescribe for you. And if you're having a procedure, you may have to come off of some of those medicines. So have a list, be able to hand it to someone, or have it handy so when you fill out your paperwork, you can fill it out completely. Know your doses and know how many times a day you're taking it. And it will turn out to be very important as well.
Yes, yes. I've seen a lot of patients will come in and their mind will just kind of go blank when they're trying to draw out what the names of medications are. So lists or even physical bottles, if you need to, is really good. So if a patient comes in, what do they expect from when they show up to clinic to the end of their visit for like their first visit for spine?
For a first visit for spine, one should expect to complete some paperwork that talks about where the pain is, those qualities that we talked about, what the number is, what makes it better, what makes it worse. Was this a result of an injury? That turns out to be important. If it was an injury, was it an on-the-job injury? Because that may change certain things. Was it a fall? Was it a motor vehicle collision? All of those things turn out to be important as well. So one will expect to come in, likely be weighed, perhaps have blood pressure taken, maybe not, it just depends. And then go into a room and give a very basic idea of what they're there for. So why are you here today? Just to make sure that it correlates with what we have on our chart work, if there's anything else that we need to do. One would expect to have x-rays of the body parts. So it's clear if it's your back and you say, oh, well, it's my back. Try to be clear in your picture or your description. Is it this part of your back, which is different than this part of your back? And then the same can be true with your neck and this part of the back. Sometimes those two can be a little bit confusing as well. Is it your shoulder? If it's your shoulder and it radiates all the way down your arm, it may not be your shoulder. It's probably coming from your neck. So, you know, that we'll try to draw out. And then after the x-rays, the physician will come in, take a history. You'll likely have to be at least partially disrobed so we can get to the area, or wear clothing that's loose and easy to get to you. In terms of socks and shoes, likely expect to have those come off so that we can check your strength and your sensation down in your feet as well. So expect a history to be taken, expect to be examined, and then expect for someone to have looked at the imaging, you know, with you and talk to you about that. I have a habit of sending the images directly to the person. So I'll send it to you on your cell phone, by email. You can look at the images yourself. And then sometimes that helps people remember the things that I had to say about them. Expect to at least get some type of preliminary diagnosis. So sometimes we don't know exactly what's wrong. We have what's called a differential diagnosis in our minds. And we'll just kind of say that. It could be this, could be that. I think it's this, but we need to confirm this. We may need to get some more tests, that sort of thing. What am I going to do about it? So, you know, are we going to prescribe you medications? There are lots of different medications we could use. We could use anti-inflammatories, muscle relaxants, but we could use nerve membrane stabilizing medicines. We could use some other types of medicines. We might suggest some different vitamins that you might take, you know, those sorts of things. And then you would expect, are we going to do physical therapy? If so, what area do you want to be in? And when are you going to be seen back? So when do we expect to see all of these things we did and came up with? When are we going to see you back for that? I could order some studies. So I could order an MRI or a CAT scan or a nerve study. Some of that will depend on insurance, honestly, because some insurances require that a person have physical therapy prior to advanced imaging studies being done. So expect that and don't assume that it won't be done. It may be that the reason it's not being done is for insurance reasons, and we'll typically let you know that as well.
Awesome, awesome. So if you have anything else you'd like to add, feel free to. Right now I'm going to start looking over the comments and see what questions we have. And if you haven't submitted them yet, this is your time to go ahead and do that. Let's see. So Miss Beverly, I'll put it on the screen as well so everybody can see, but what can be done for compressed disc in the lower spine without doing surgery, physical therapy, or when physical therapy made the pain worse?
So physical therapy made the pain worse. There's two things to consider. Did we do the right physical therapy based on your examination? Was there directional preference established? If that was established and things still didn't go well, and the therapist tried multiple things or even consulted with another therapist and didn't just hand you some exercises and say, go do these, then other things that can be done will depend to some degree on how compressed the discs are. So and if there's anything else going along with the compressed discs. So sometimes we do epidural steroid injections. There are certain procedures that can be done if there's a lot of in-plate changes to kind of help the pain that comes from that. And that's a more advanced procedure. It's not considered an injection. And then, in addition to that, we'll look at, what are your medications? What are your activities of daily living? Are there things that you can do that can help mitigate some of that as well? So generally, medications, injections, potentially a change in therapy, and then kind of a reevaluation to make sure that that's not the only reason that you're having pain.
Awesome. Next question is from Miss Felicia. She says, what non-surgical options are there for when you're older? She says 93-year-old woman with lower back pain.
So for a 93-year-old woman with lower back pain, the first thing we need to try to do is establish a diagnosis. So does the back pain radiate? Does it stay in your back? Is it better if you're sitting? Is it better if you're standing? Is it better if you're walking? If I examine you and I have you lean or bend one way, does it hurt any more or less than if I have you lean or bend the other way? That and the imaging studies help to establish a diagnosis. Once we establish a diagnosis, we start talking about what can be done. So we have to be very careful with medications in people who are in their 90s, and so we try to minimize or not do those at all. If we have to. Sometimes we'll use what's called compounded medications, which are prescription medications that are made at a compounding pharmacy that you apply, and it'll have a variety of medications so that you don't get the systemic absorptions. Sometimes there's certain targeted injections that we can do, trigger point injections, radiofrequency ablative procedures, epidural injections, and all of those can be safe and easily done in people who are in their 90s and even close to 100 or 100.
Awesome. So it sounds like who Miss Felicia is talking about needs to come see you here at OrthoSouth. Let's see. Next is Miss Shirley. She is questioning about a 71-year-old female, had several nerve blocks. Pain came back 6 months to a year after those nerve blocks, and then she's having that sciatic nerve pain. It also says some prior history is L4 rupture, L5 bulging, and limited to do housework. Mm-hmm. What would you say?
So I think it's important to determine if it is both of those disc bulging, one or the other, and sometimes things kind of play into each other. So I generally start out by, again, doing the examination, trying to figure out, what has happened, and then what injections did you have done, and what was the approach to the injections? Was it more intralaminar injections? Was it transforaminal? Was it both? Was a caudal approach taken? And if you were better for 6 months, how much better were you, and were there any residual areas of pain? Depending on that, we may consider doing a nerve study. And it depends on if the pain is in the back or if it also, like you said, the sciatic pain occurring. So then we may do a nerve study to help find out, to see if there's another area of impingement that also is contributing to that, or if there's actually nerve damage that contributes to that. Depending on what happens there, we could talk about potentially some longer-term procedures that might be of use. Some of it depends also on the size of one's spinal canal, so we'd have to look at that as well.
Awesome. All right, Miss Gaines, she says that it's in her buttocks, knees, and burning into your calves, which describes that sciatic nerve, that radiculopathy. I feel like this is kind of same scenario as everyone else, kind of come in and see about the injection, see about physical therapy. Is there anything else you'd like to add for that?
I think it's really important first to establish a diagnosis and a level. So when we think about what's called sciatica, and I think this was discussed in Dr. Stewart's webinar as well, is it the nerve roots of the sciatic nerve? If so, where is the problem? Is there a component of piriformis syndrome? Is there a component of sacroiliac joint problems? what are those? And if so, is it a combination or is it a single thing? Once we figure that out, then we can start talking about whether or not injections, and I almost always combine, not almost always, I always combine injections with physical therapy, even if it's 2 or 3 exercises. So what studies have shown is that you don't necessarily need 10 exercises to do. What you need to do is establish the directional preference and what exercises from that should be done. And if you have 2 or 3 or 4 good exercises, that can be just as effective, if not more, than having 10 or 12 things that you do. So even if a person comes back to me and I've done some type of injection or done some type of advanced procedure and they say, I am 85, 90% better. The next question that I'm going to ask is, what are you doing for exercise? And then I'll ask them questions about their lifestyle, their housework. Do their bones move evenly on each other when they go from bending to straightening up? Should they wear some type of brace when they're doing heavier work and not wear it otherwise? So those are all the things that we talk about on that follow-up appointment. Even if the person feels like their pain levels are 0 to 2 and they don't really need any other intervention, we need to then kind of focus on their life and find out what they can do better.
Yes. Yeah, so is there a difference, or would you say there's an advantage or disadvantage to having formal physical therapy at a physical therapy place versus having home exercises?
I think initially most people could benefit from having a formal physical therapy evaluation by a spine-trained therapist. And it's very important to have the therapist kind of match you. So it's just like when you go to see a physician, you have to be able to communicate well with that physician. You have to like that physician's either the way they explain things or their bedside manner or a variety of things. The same is true with the physical therapist. And then what does the physical therapist come up with? I have a lot of patients who've already tried some exercises on their own that they found on YouTube. There are a lot of physical therapists who have programs on YouTube that are focused towards a specific thing. And sometimes I'll have patients that I will evaluate and they found a program and I look at that program with them and I say, stop this, do this, stop this, that sort of thing based on my physical exam of the person and matching that physical exam to what I've read in the MRI. Which is another thing. If you have had imaging studies, make sure we have the actual imaging studies because we all look at and read our own MRIs. We like and trust our radiology colleagues, but sometimes we look at things differently, and sometimes I'll call a radiologist and say, I see this and I see it's not on your report, or what did you mean by this because I'm looking at this. Those kinds of things happen and we discuss it and literally I talk to a radiologist every single week. And so one could expect that's going to happen. So sometimes I'll give a person an exercise program myself. Usually it's because the person has extremely limited time. They've been to physical therapy. I have them bring their exercises with them, and I go over them with them, and kind of give my opinion on it. Or they are extremely rural, and it is, it's a long drive there and a long drive back, and they have a social situation that does not really allow for that. Either a dependent family member that they just can't be separated from that period of time. And in those cases, I'll do my own, but I typically like, if at all possible, to help match them with a physical therapist who can meet their needs.
Awesome. So kind of circling back to what you were saying about showing back up for that follow-up appointment when you have a 0 or 1 pain scale, and just want to kind of emphasize that again about your 0, 1, great, you're better. That doesn't mean like pause. It means let's see like how to keep you there. Is that what you were saying?
Exactly, because sometimes a person will come by and they'll have a 0 to 1 pain and they'll say, okay, well doc, can I start running again? And they have this big disc extrusion that I know didn't all resorb in the few weeks since I last saw them. And I'll examine them and they still have a bit of a sensory loss. They still may have a little bit of weakness, and I'll say, okay, I know that your goal, and I do talk to people about what is your goal? So if your goal is to play golf, if your goal is to run, that sort of thing, is that a feasible goal, and do you understand what that means for you, and do you understand how you're going to get yourself there? And so that we don't go from 0 to 80.
Yes, yeah, that's good. Especially when you get that pain relief. It feels amazing. You don't want to stay there. Let's see. Miss Elizabeth says, can you tell a little bit more about the ablation procedure? And I'll pull up, while I have that question on there, I'll go ahead and pull up that RFA. There we go. So now you've got the RFA on the screen for everyone to see.
So ablation procedures are meant to address the nerves that come out of arthritic or dysfunctional facet joints. And facet joints are the joints that connect one level of our spine to the other one. So this is a facet joint, this is a facet joint, this is a facet joint, and going all the way up the spine. And so with this model, and really models don't show this, but what this model doesn't show is that there are other little nerves that come off of this big nerve that supply these joints. So every joint has a 2 to down here, 3 nerve supply. And what we do before we do an ablation, first we have to establish by history and physical exam that it may make sense to do an ablation. And after we establish that, then we have to do 2 test injections. So back before insurance changed this, one just had to have 1 test injection, and then you could do it. And the test injection is an injection of just a mix of anesthetics. There's no steroid at all. And so, for instance, at our surgery center, you'll come to the surgery center, you'll go under an x-ray machine, and that x-ray machine, that C-arm is going to rotate around and tilt up and down and guide me to where that nerve is lying. When I get there, I'm going to inject some dye, and then I'm going to inject a couple of anesthetics in a mix. And I'm going to do that for the nerves that supply that joint. And then we're going to tell you, don't go home and go to bed. Go home and do the things that would normally bother you. So even in recovery, we may say, look, if standing's a problem, we want you standing up as soon as possible, walking around so that we know what happens. And during the time that that anesthetic is active, if the person gets, and the benchmark now has been increased, it keeps going up, but the benchmark has been increased by insurance to 80%. If one gets 80% relief with an initial injection, and for some insurance companies it's 50, so they have to have a mix of 50 to 80, and for others it's 80 for both. Some it's 75%, but whatever that benchmark is, if the person meets that benchmark for any period of time in the immediate time frame or short-term time frame after the procedure, then they can go on to have an ablative procedure. During an ablative procedure, one comes back in, and the needles that are put in this time are slightly different. So those needles are put back to the same place that we did for those medial branch blocks, which are the test injections for the radiofrequency procedure. But then little stylets are little guide wires that are in, that kind of guide the needle. So the needle's kind of a hollow tube, right? That's how you can inject medicine in it. So there's this little guide wire inside, and you pull the guide wire out, and then you put another wire in. That wire is connected to a cable that's connected to a computer. The computer is going to take some readings to let you know if you have the right impedance for the area that you're in. So your nerve structures have a certain impedance, bone has a different impedance, that sort of thing. If you're in the correct range, then you can start the test for each level. So your assistant, which will be the nurse, is going to turn it on. Then the computer, after you get the reading from the impedance, the computer is going to send a signal. The signal is not going to be a painful signal. It could actually be so slight that initially you don't even know you have it. But as soon as you have it, you let us know, I feel that signal. Then you're going to be asked a follow-up question. And that's because we want to make sure that we have just the nerve we want and not any other nerve. So you shouldn't feel it traveling on down your leg, or if we're up in the neck, you shouldn't feel it traveling on down your arm. So we're going to ask that test question. And then there can be a motor test done as well. After we're done with our testing, at each level, and the thing to remember is that each level could feel slightly different than the level before it. Some could feel the same, they could all feel the same, but follow the directions you're being given during the ablation procedure in terms of when you answer the question. After those questions are asked, then we inject some very, very strong anesthetics. So normal anesthetics for this might be like 1% lidocaine. So in this case, people may inject 4%, so 4 times the strength, or even a medicine called bupivacaine, which lasts a little bit longer. Anyway, we wait for a little bit for that to work and then turn the computer on, and the computer does the lesion. At that point, the person really should feel nothing or maybe a little bit of pressure, but you certainly shouldn't feel any pain during that procedure. And then all the stylets and the needles are out, Band-Aids are on, and then you go to recovery for your instructions.
Awesome, awesome. So I kind of want to wrap up here. The title of this webinar is The Role of a Physiatrist in Comprehensive Spine Care. So kind of in conclusion, does a physiatrist start at the beginning before surgery, or can the physiatrist go before, after surgery? How does that all work?
Sometimes we go before surgery, so most of the time we go before surgery. It just depends on where the point of entry to our system. So some patients will start out with the surgeon, and then the surgeon will then send the person back to the physiatrist for the injections or that sort of thing. Many times they start out with the physiatrist, and then we direct everything leading up to the surgery. We all hope that surgery always goes 100% well and the person does fabulous and they don't have to see any doctors after their couple checkups after surgery. Sometimes it doesn't happen. Sometimes people get some nerve irritation afterwards from inflammation, other things that can happen, and so then we can end up seeing the person again afterwards to kind of direct their recovery. Sometimes their muscles got so weak before because they couldn't do the therapy, or they just were really deconditioned before and they need to be reconditioned afterwards, especially with some of the much larger surgeries. And so we may end up seeing the person afterwards for a period of time to direct their rehabilitation afterwards as well. So it could be at any point in their care.
Awesome. Any final thoughts, any final words before we close tonight?
I think the thing that I would like to say is, first of all, thank you, but also that I am very thankful and excited to be at a multidisciplinary spine center. I was at one before in Illinois, and it was wonderful to be able to work with the specialists together so that people knew when they referred in that they referred to a center and not just a doctor. Although that, you know, is very great and gratifying. Everybody doesn't need every part of our practice, but that we can all work together collaboratively has been very exciting, and I think it is really for the better or for the good of the people in this area that seek our services.
Yes, I agree. Especially being patient navigator, I see the moving parts, and I love how we can get everybody through smoothly. So that is awesome. Well, closing tonight, just thank you everyone for watching. If you'd like to make an appointment with Dr. Lee-Sigler or any of our providers, the information will be displayed in just a moment. Next month, we'll have Dr. Abrams with us, who will be covering a topic to be announced. It'll be Thursday, July 17th, so that's just in 2 weeks at 6 p.m. Thank you everyone for joining.
Thank you.